I think we all know about the way AS progresses, and it is useful to remind you. I mean, I remember when I was, younger in my training, and I would get the path reports from people I'd sent to surgery, and the path report said atherosclerotic aortic stenosis, and it turns out that you have T cells, LDL cholesterol, and monocytes enter through the endothelial border into valves, just like they do into arteries, and then oxidization occurs here, and then what happens is there's all these fibroblasts in the valve tissue, and they get activated by Wnt3 and other cytokines and become osteoblasts and begin laying down calcium. And that happens in coronary arteries and peripheral arteries as well, but it really happens in the valves. So you start out normal, you begin to get this atherosclerotic calcification, aortic sclerosis, maybe a little bit increase in the velocity or none. Then you get sort of moderate AS, and then you get severe AS. And as we talked about yesterday, it's really useful to look at the picture of the valve and not just focus on gradients in valve area. But that's the progression. So Ross and Brunwald published this classic paper in 1968, and if any of us tried to send a paper to circulation like this, it would get rejected without review. Why? Because there was no data in it. And so why is it a classic paper? Well, because subsequent clinical experience and data proved that they were right, so they were clairvoyant, and that's why we call it classical. But what they basically said is once you get symptoms, you go for years and years asymptomatic, but once you get symptoms, your mean survival, 2 years for heart failure, 3 years for syncope, 4 to 5 years for angina. And that's sort of been in there for a long time. Now, back in the old days, if a patient had a late peaking murmur symptoms, they would go to the cath lab and be found to have severe AS and go to surgery. Once echo became good for assessing AS, we started realizing there are plenty of asymptomatic patients out there. And here are 3 older studies that looked at them, Kelly, Pellica, and Rosenheck, and different, a couple hundred patients, follow up 18 months, 22 months. And what they showed is that, people did develop symptoms, about 40% over this course. Very few of them died. And if you look at these papers, only 1 death was sudden. The people that died developed symptoms, were told to have surgery, and refused to have surgery, and then died. So really, the risk of dying in an asymptomatic patient is low, and therefore the traditional teaching has always been that symptoms, not hemodynamics, are the primary indicator for valve replacement and aortic stenosis. So one could take a conservative stance and say, you shouldn't operate on people or leave them alone. Just to remind you, though, this is a bad disease. This is a slide I borrowed from Murat Tuzcu, and basically if you look at metastatic cancer, not just cancer, metastatic breast cancer, lung, colorectal, prostate, ovarian, have better survival than severe inoperable AS. So AS is very bad for you. That was shown in this study. This is an old study, 35 years ago. These are patients who got operated on for AS on the top curve, good survival, and if you got turned down by a surgeon because you're too sick with AS, you have an abysmal prognosis. And then recently, of course, the Partner B 5-year results really confirm that. You start out with 179 patients here in the medical treatment group, which is really randomized to death, and then only 3 are alive at 5 years, so 98% rate of mortality in those high-risk patients. So that's why when we see somebody that's asymptomatic, we do worry about them. Although those were symptomatic patients there, I think we have to think about the importance of symptoms. And it's true that you can't make an asymptomatic patient feel better by surgery. That's true. It's also true that the risk of sudden cardiac death in asymptomatic severe AS is low. However, you have to take a careful history. Not all asymptomatic patients with AS are asymptomatic. So I have been, for several years now doing a multidisciplinary valve clinic with our surgeons and interventional cardiologists, and I have learned that this bottom statement is very true. Now Mark Twain is famous, for his quotes, and get your facts first, then you can distort them as you please. We do that all the time when we put together these talks, right? Do the right thing, it will gratify some people and astonish the rest. Taking a history is doing the right thing, and it will astonish people when you do that. I like this one. When angry, count to 4. When very angry, swear. And of course, you all know the lies, damn lies, and statistics. But Mark Twain is famous not just for quotes, but for his storytelling. So I got to tell you a story that illustrates the point. So when I was a fellow in cardiology, the 4th richest man in America came to see Dr. DeMaria, my mentor. And Dr. DeMaria gave instructions that no resident medical student or house officer, fellow, anybody was to see this guy, only him. But I didn't get that message. My beeper went off, said there's a consult, go see him. So I go see the guy, and he's asymptomatic. I mean, he has Y chromosome disease. I mean, he is not going to admit to another man that he has shortness of breath or any problems at all. That would be very unmanly. So naturally, he's a 68-year-old guy, tough guy. He's not admitting to anything. So I did this smart, intelligent thing, and I looked at his beautiful daughter and said, well, is it true that your dad is really asymptomatic? You don't see any problems? She said, that's my husband. I'm already thinking Dr. DeMaria is going to kill me, but and he nearly did. So I have you learn things in your training and even in your practice. One of the things I learned is never ask a woman if that's her dad. Absolutely. Never ask a woman when the baby's due. That's another one. You just don't want to do that. But I have found if you take a history carefully and ask the family members and ask the patient what they were doing a year ago and what are they doing now and why, you can often draw out symptoms in these asymptomatic patients. You don't even have to waterboard them. You just have to take a careful history. So what do the guidelines say? Well, basically, the prognosis is poor once there's a peak velocity above 4, mean gradient of 40. That's from Catherine Otto's paper. Prognosis is worse when the AVA is less than 1. However, it also says, and you heard this yesterday, that an AVA of 0.8 is what correlates with a gradient of 40, not an AVA of 1. Symptomatic patients who have an AVA of 0.8 to 1 should be closely evaluated, and the inherent variability of the measurements and calculations need to be considered in clinical decision-making. I think all of those things are pretty straightforward. But the guidelines also point out that there are some reasons to think about operating or intervening on an asymptomatic patient. First of all, they say that if you're asymptomatic and you're stage C1 or C2, you really should consider an exercise test. I do this all the time. If patients tell me they're asymptomatic, I'll say, come with me down the hall, and I'll put them on a treadmill, and it's very common that after 30 minutes they poop out. And they'll often tell you that they don't have symptoms. Then the other thing here is the symptoms are listed here, and I think it's important to say, fatigue is on there. And a lot of times these patients will tell you, I'm just worn out, doctor. I can't. They'll deny shortness of breath, but they'll say, if I try to do anything, I'm just worn out. That counts as a symptom. Guidelines say then that AVR is recommended for asymptomatic patients with severe AS and an EF less than 50. So remember that. EF less than 50 buys you an intervention. It also says asymptomatic patients with very severe AS, that is a velocity above 5 and low surgical risk. So the guidelines are already allowing you to do asymptomatic patients. Decreased exercise tolerance. You can get that by history. The patient may tell you that they used to go to the gym and walk around the track 6 months ago, and now they don't do that anymore. That's symptomatic. Exercise, fall in blood pressure. And then finally, asymptomatic patients who are having rapid disease progression. Now, the Tavor Guidelines basically say Tavor is recommended for people who should get AVR but are at high surgical risk. So the same thing applies, whether it's surgery or TAVR, the same thing applies. So the conclusion is you treat symptomatic severe AS, most are symptomatic by history or exercise test, and you treat asymptomatic severe AS if the EF's below 50, the peak velocity is above 5, or they have decreased exercise tolerance or exercise drop in blood pressure. And just finally, take a history, a careful history. Thanks.